Sorry about that delay. A very warm welcome to our panel. Let me introduce, well, you're not panel, you are speakers, but let me introduce our speakers to you. And our topic here is our responses to the pandemic in different regions. So we're going to get started with Professor Marius Pieterse, who is a professor in the School of Law at Wits University, where he teaches constitutional law and human rights law. So I think we are going to have a fascinating input from him around interventions and accountability structures. So thank you very much, Prof. Let me introduce all our speakers so that you get a sense of the richness of this session. Our second presenter is going to be Professor Frode Forland. I hope I have not got your name too bad, but he is a director of infectious diseases, prevention and control, director of infectious disease at the Norwegian Institute of Public Health. He has a particular interest in the control of bloodborne and sexually transmitted infections. So we're very privileged to have him from the far north. And closer to home, we have Professor Rhoda Wanyenze, who is the dean, is a dean at the Makerere University. She's dean of the School of Public Health. She's got a vast experience in infectious diseases research, capacity building, and program management, especially in the areas of HIV and TB. So we are so lucky to have, if we look at the north-south of our globe, someone from here, someone from the middle, and someone from the top. So we'll start in South Africa with you, Prof. Pieterse, then we'll go to you, Prof. Forland, and then we'll go to you, Prof. Wanyenze. I will help you with time, if that's all right. We've got about 15 minutes for each of your presentations with a bit of time for a couple of Q&As. You know, participants, have you seen in the Q&A, we're not going to get to all of your Q&As, but do vote for each other's questions if you're interested in them too, so we can get a couple of questions to each person. If you will indulge me, presenters, when your time is up, I will let you know. So don't be offended if you hear me coming in and saying, I'll give you 2 minutes, and then when you're finished, I will say your time is up. So let's start with you, Professor Pieterse. You're most welcome. Thank you.
Thanks, Jeremy, and hello, everyone. Whilst I try to share my screen.
You've done it.
So I'm assuming I've succeeded.
Congratulations.
Thanks very much for having me. I'm talking to you today, as Jeremy said, as a constitutional lawyer. I'm interested in how systems of governance at various levels are sort of constructed and maintained. And so in a way, I'm in this session, but I'm also leading into the session that you'll have on the law and legal structures later. And I'd like to start with a plug for the initiative that is both the reason I am here and the source for what I'm saying. This Lex Atlas COVID-19 is this global academic project driven from University College London. It's linked to the production of Oxford University Press's Compendium of National Legal Responses to COVID-19. And I coordinate the South African team for this, which, and we all sort of do what it says on the tin. We compile the national legal responses to the pandemic in a way that enables comparative research. The compendium is a work in perpetual progress, and we are forever updating. The first phase, which I base this talk on, looks at public health responses and their integration into constitutional systems in a bunch of countries. And then as the project expands, it takes in more countries, and then it expands also to social and economic support measures. And as I say, we have to update constantly. And so the project enables us to understand the many similarities and differences between responses in different parts of the world. And then we can also contemplate both best practice and common areas of concern. And so today I just want to briefly reflect on some of these. The pandemic hit the world fast, and the world, for the most part, wasn't ready. Countries everywhere obviously had to respond from within the legal and governance structures that they had in place already. And then when those didn't work or proved inadequate, they had to supplement them, and quickly. So I want to look today first at the frame that states used to anchor their responses, then from where the responses were driven, and in terms of which instruments, what those instruments typically contained, although I'm not going to say too much about that, and then where and how accountability resided in all of this. Now, starting with the frame, COVID is a public health emergency, and so the obvious frame for a response, one would think, would be public health law, or so it would seem. But overwhelmingly, this proved not to be up to the task of this pandemic. And like the health systems that public health law props up, it was simply overwhelmed by the sheer scale of the pandemic. And this is partly because public health law tends to have been neglected in most systems in recent years, partly due to complacency and partly because its logic of imposing interventions, restricting liberties, and so on, sort of sat uneasily in rights-based systems that are fixated on liberty and choice. So that legal systems around the world tried usually to deal with disease in a sort of a soft law, persuasive rather than coercive way. And in most places, such mechanisms as that exist also sort of functioned and were conceptualized at a much smaller scale. In South Africa, for instance, our quarantine and isolation regulations were last updated in response to XDR-TB. And they envisaged sort of last resort style detention in health facilities to curb spread. But this simply could not scale. And it came with so many processes and safeguards that it would also be ineffective. Indeed, the only places where existing public health law frames seemed to be adequate were those like Hong Kong and Singapore, which adapted their systems and aligned it to strong executive-driven, rapid and large-scale interventions after the 2003 SARS pandemic. And so there they had something in place that they could just mobilize. Almost everywhere else, it was necessary to look elsewhere. And so many states sort of first toyed with national states of emergency, but these were also problematic for various reasons. Many constitutional systems simply don't allow for them. Where they do, it is subject to extreme safeguards. And the supporting legislation tends to envisage military siege. And so the measures that they contemplate tend to be far too hard and uncompromising and militaristic. And so where they were used, like in some of our neighbors, I know Botswana had a national state of emergency, they tended to have to be supplemented with more context-appropriate measures. And most countries sort of ended up not opting for them. In places like South Africa, New Zealand, and Italy that had contingency or disaster management legislation, they tended to opt for that, since it tended to contain sort of intervention and support type structures and machinery that could be repurposed without too much difficulty for the content, although doing so was often clunky and tricky. And so many places, notably the UK, had to actually draft and fast-track new coronavirus-specific legislation that could do things like authorize large-scale lockdowns that their systems previously couldn't even imagine. Overall, I think we find that the frame that was chosen in a particular place sort of predicts the nature of the response that we then see in that place quite well. Sweden, for instance, has a strong rights-based system of public health law, which is progressive and relies on soft enforcement and voluntary compliance. And since their constitutional system doesn't allow for states of emergency, they use the health frame. And when the figures showed after the first wave that it didn't work and the public started getting antsy, they supplemented this with specific legislation in their second wave that allowed sort of a slightly greater degree of top-down restrictions. Hong Kong, on the contrary, has a strong executive dominant constitutional system, with a strong top-down public health system allowing for sort of short, sharp, ambush-style mini lockdowns of individual buildings and areas and so on, which is aligned with criminal law enforcement. It was fashioned and tinkered in response to SARS, and although controversial, it worked for COVID, so that they never needed to declare a national state of emergency or indeed a nationwide lockdown. This Hong Kong example then leads nicely, I think, to the next issue, the issue of from where COVID responses were driven, because the Hong Kong system, where the executive dominates and where there's no real federal power sharing, because it's a single city for good reason, it's not a very popular system to have an executive-driven system, because it seems a bit authoritarian and centrist and top-down and unaccountable. But we saw most of the world rushing, perhaps alarmingly, to exactly that. Countries left, right, and center found ways within whichever emergency frame they chose to drive the response, firstly from the executive, and secondly from national level. The few exceptions being countries like New Zealand, where the legislature ordinarily dominates, or then strong federal systems like the US and Canada, where the response was on state rather than on federal level, and where this tended actually to be a weakness, with fragmentation and inconsistencies fueling the pandemic. Brazil was an interesting semi-exception here, because Bolsonaro's opposition to lockdown-style measures at a federal level led regions and municipalities to use their powers instead to impose lockdowns and so on. And when he tried to stop them, the court sided with them. But this lack of coordination was obviously also a main weakness of the response there. In South Africa, the sort of Disaster Management Act has quite convoluted and federalist structures at various levels, national, provincial, and local levels. They proved in some respects too cumbersome, and so they were sort of supplemented or sidestepped by the creation of the National Coronavirus Command Council, which is basically cabinet functioning under another name, but then supplemented by premiers and some metro mayors. As you may know, this was challenged by opposition parties, but it was upheld by the courts, who found that cabinet could form such committees as it pleased to oversee implementation of legislation such as the Disaster Management Act. Executives around the world then tended to rule this pandemic through decree or regulation, depending on what the legal system allows. And we typically saw, initially at least, a range of sort of hard command and control type instruments, combined increasingly as time went on with softer tools like recommendations and guidelines. And in combo, these usually then worked as good as they could, though administratively they were a nightmare in their sheer volume, and their need for regular updating and repeal and replacement and modification, which has seen most countries' legal landscape around this pandemic turn into near unmanageable clutter. I'm not going to say much about the nature and content of measures themselves, since these come up several times throughout your program. Just to say that responses typically had quite a lot in common across the world. They all started converging as science around the virus progressed and as more became known about what worked and what didn't. Most places started with quite far-reaching lockdowns of a kind that would not have been possible under the ordinary public health legislation, as I've said. And with time, and then typically from second waves onwards, these became more balanced and flexible and more intricate, as countries started experimenting, often out of necessity, with sort of graded or tiered or localized lockdowns to enable economies to function. Almost all systems then made provision for quarantine and isolation, though many tried to do this initially within their institutionalized frames, and which provided typically for quarantine and isolations within health institutions. And the scale of the pandemic soon necessitated them resorting to going outside of this and going for self-isolation, and with assumed rather than policed compliance. Simultaneously, contract tracing systems where they existed soon fell behind and were often abandoned. There was, however, distancing laws and recommendations passed everywhere. And while masks, for instance, were not an initial thing, they sort of made their way into regulations as their benefits became known. Here, for instance, They were first optional, then recommended, and then mandatory as it became economically necessary for people to venture outside, and then as their benefits became known. Most systems then did things like closed schools, prohibited visits to hospitals, old age homes, prisons, and the like. Many introduced curfews and banned gatherings. And then there were some more fringe provisions, like South Africa's alcohol and cigarette bans, which were only taken up by a small handful of other places and not to the same extent. Finally, then, just a few words about accountability. Rights and monitoring groups around the world watch nervously as executives gain power, while typical accountability structures either scaled down or slowed down, at least initially. Parliaments tended to maintain oversight everywhere, but they also tended not to really second guess much of what was coming out of the executive. And a lot of the framing legislation where it was new, that I mentioned earlier, was fast-tracked through special processes, and typically, for instance, community participation processes were put on ice. Similarly, courts could and did review measures in a range of challenges, here as much as elsewhere. There's a long tradition of proportionality review of public health measures that limit individual rights in many systems. Though while they all predictably saw many cases, it does seem that courts everywhere have tended to also side with executives and uphold measures more than what was perhaps expected. Indeed, the most common and consistent actually functioning check on measures has tended to be built-in sunset or review provisions that required executives themselves to periodically renew measures, review and then renew measures, which obviously then often led to them being reconsidered and adjusted. And so here we are, just over 18 months later, in a world slowly emerging thanks to vaccines from the thick of things. But looking around, one sees systems and institutions that have taken significant strain. And it's going to take some time to see whether executives firstly easily surrender the authority that they've been exercising over everyday life and that they've become used to vis-a-vis other institutions. And I'm particularly interested in my work on local government to see whether local governments emerge again from under the sort of state of national subservience that many of them have been existing under for more than a year now. It would also be interesting to see whether after this there's large-scale public health law reform over the next few years, similar to what we saw across Asia after SARS in the early 2000s. And so legally and system-wise, at least it's not yet time to stop holding on to our seats. Thank you.
Thank you so much, Professor Petersen. A fascinating presentation. And I find it quite reassuring to hear the other countries and the measures that we are all grappling with a set of instruments which are trying to catch up with a pandemic. So thank you so much for that legal lens. And you can see the screen's going mad, appreciating your input. Thank you very much. Let me also just, a number of you might be wondering, who is Nicolene on your screen? Nicolene is a uniquely talented graphic harvester who will be sharing at various times with us a representation of what's been discussed. So Nicolene, what I'll do is I'll bring you in at the end of the segment after Professor Wanyenze has presented, and we'll ask to have a look at what you've prepared for us, if that's all right. Thank you. Let's go on to the north, to Norway, to Professor Forland, who's the Specialist Director at the Norwegian Institute of Public Health. What has been your response in Norway to this pandemic? Over to you.
Thank you so much. Can you hear me now?
We can hear you, Prof. We're just seeing
Cannot see my screen.
Yeah, we can see our own screen. So I think it's a setting. If that's great, if you can
coming
just
up now.
It's coming up fine. You can add on. That's perfect. We should get your screen view now. Okay. I think what we can do, Prof,
control.
is just take your slides as they are now. If the presentation mode is not working, we can still see what you're presenting. So please proceed with your presentation.
Okay. You see my outline there?
Yes, we do.
Okay, I'll jump from the other screen then, I suppose. What happened here? That's always the case of two screens.
Yes.
You don't see my slides moving.
No, we are just seeing.
Sorry.
Okay, now we can see it moving. Now we can see it moving.
Okay, I'll keep it there. Thank
Yes.
you very much for having me.
Good.
And good morning, everybody. Good morning from the far north. And I was actually in Stellenbosch University March last year, when I think the first reported case came up from a boat or something, a cruise in South Africa. And then being at the annual meeting for the Collaboration for Evidence-Based Healthcare in Africa. So I've been working also a number of years in Kenya and in Zimbabwe as a medical doctor. And I'm now the in position of Director of Infectious Diseases at the Norwegian Institute of Public Health. And I'll say some few words about the national machinery here, the Norwegian Institute of Public Health, its role, update you on the situation in Norway and the Norwegian strategies that has been through the pandemic, and also touch a little bit upon the role of WHO and the reviews that we have done related to going through the learning points of the pandemic so far in Norway, and also showing you a little bit of how we've been dealing with the evidence. So the key areas of work from the Norwegian Institute of Public Health is that we are working on three main areas of creating knowledge and having the responsibility of a preparedness organization for the government, and also to keep infrastructure. So on the knowledge side, we do research analysis, we are keeping surveillance systems, doing literature reviews and reports and bulletins and all that stuff, and giving out handbooks. On the preparedness side, we're having preparedness laboratory every day, every week, infectious disease control officers on call, communication officers, and we're the local focal point for the IHR, the International Health Regulations, which might not be familiar to all of you, but I think you can look upon it as the global public health law, which gives a lot of requirements for all countries, which I'll come back to. And on the infrastructure side, we keep the surveillance systems for infectious diseases with a lot of registries, with all those abbreviations. We keep the reference labs for 30 bacteria and viruses, biobanks, and also those database registries, which ends up in recommendations, advice, information, publications, and communication, and so on, to the government and to the public and to the health services. Just to remind you shortly about this disease pyramid, which I think is a kind of reminder of what we are talking about when talking about infectious diseases. We are starting at the end, at the lower end here. We see the number of exposed is the highest number. Then comes the people without symptoms, which still might be many with corona. Then those having symptoms that are fewer. And then those who are getting in touch with the doctor, the GP or the nurse, those with a positive test, those who are hospitalized on top of that, and those ending up in intensive care. And not on top of this pyramid, the few people who actually die of the disease. And we've been trying to capture data from all those different stages of the disease pyramid, as you can see on the right side. On the top, reporting of deaths is an obligatory reporting. And then we have the registry for intensive care in Norway, the National Patient Registry for all hospitalized patients, the infectious disease registries for all with a positive test, and then a disease registry for everybody who's been to primary care and getting their reimbursement from there. And then we have also developed new systems to keep a track of people having symptoms and people with studies infected without symptoms in prevalent studies. And finally, also, we are getting now more information about those who are exposed through contact tracing apps that we are running in the course of the COVID. And then all those 5 on the top there, we've collected them into one registry. So we are able to really analyze the data as we are working through the pandemic and through the different stages of the pandemic. I brought to you this picture just from February last year, because I picked it up then because I thought it was very funny. this is from South Korea, I think, and it's actually the cabinet, and they are all sitting there with gowns of infectious diseases and face masks. And this is something we'd never seen in our part of the world at that time. And I thought it was funny to see how they were exaggerating the measures. And then rather few months later, this is myself sitting at the airplane in Norway with everybody around me with a face mask, which then had become obligatory and a compulsory thing to do, even in Norway. So like the former speaker was talking about, there has been measures that we never thought of were possible in a lot of countries that have now been like the rule of the day. And then in the beginning of the pandemic, we were really discussing what kind of scenarios will we have? What kind of waves will come? Will this be the big first wave and then only smaller waves? Or will there be a bigger autumn wave, or whatever you call the time of the year in the north and the south? And it was really a case of understanding how a development of a pandemic will come up. And a lot of the experience that we'd had so far was really connected to the development of the influenza season pandemics and season epidemics. And we really didn't know what would happen. And these are then the figures of some of the escalations in Norway. These are showing the total number of cases that we have registered since March last year until August this year. And you can see there are waves. And looking at this figure, it looks like the bigger wave has been now in the second half of the pandemic, the autumn wave and the winter wave, we can call it from a Norwegian perspective. And then you also see that there is a rise in cases now at the end of this timeline, which is connected to the Delta virus. But that's the total number of cases registered. And what we then have to remember is that there was a severe underreporting of cases in the first phase of the pandemic. So when looking at the patients being hospitalized, we can probably see that the total number were the highest in the beginning of the pandemic of the spring last year, in March, April, May last year, with near to 300 cases admitted to hospital per week. But we see also we have substantial numbers in these two second other cases. And we see very few actually now lifting up to a higher number in the last increase of cases of the Delta virus. And then the strategy in Norway has actually been expressed by this slide, I would say, to preserve health, avoid societal disruption, and protect economy. And from the 12th of March, we call this strategy a knockdown strategy of the spread. Then we were installing massive measures across society, non-pharmaceutical measures, to prevent overburdening of the health services, and also to gain time to prepare at all levels of the society. And then I would say, surprisingly fast, we got already from the beginning of April a rapid decrease in the numbers. And then from April 20th last year, we started to call it a control the spread strategy, with a gradual de-escalation of measures, controlled reopening of society, and active testing, contact tracing, and isolation as the main issues that we should stick to. And then still also to prepare for re-escalation of spread, both locally and nationally, and also relating to what was happening in other countries. So this reopening stage then was what we called a stepwise and controlled way of reopening society, from mainly from April to August last year, where the first was to care for the kids so that they shouldn't have too strong measures, including closure of schools and so on, because they were definitely the least affected group of the population. Second priority, get people back to work, keep social distancing and hygiene measures, protect the vulnerable, which was, of course, protecting those who were at that time most vulnerable for getting seriously ill and getting hospitalized and dying, those people who are at a higher age. And then coming to reopening of leisure and fun activities. And we saw from an early stage that this has to be a whole of society, an all of society approach. It's not only connected to the health services. And it has to come from a critical awareness into daily routines of dealing with all these measures. And then, of course, there was always the question of also finding and understanding how this is a pandemic, not only an epidemic or a pandemic of Norway, understanding how we are also affected by what happens in other countries. And then from August last year, I would say we've had this adjustment of the national and the local measures ongoing, with the societal measures that we have seen being effective, but very costly, being added at a higher level when there was an increase in the transmission rate in Norway, and also with a lot of local and regional measures according to the spread of the pandemic in different municipalities of Norway. And in Norway, the legal regulation is very much connected to the responsibility of the municipality, with a local responsibility for stopping the outbreaks. And they could also install local measures, and like connected to travel, to number of people gathering, schools and kindergartens, we introduced what we call the traffic light system there, with green light, yellow and red, with numbers of cohorts and numbers of people in the class and so on. And also measures related to face masks and opening of restaurants and bars and so on. And on national level, of course, the question of border control has been important throughout the whole period. And we've had a very strict border control in Norway compared to, for instance, our neighboring country, Sweden. And then at the end, we've seen vaccination coming up as the way out of the pandemic, as far as we hope and can see. And a few words about WHO. And this man has probably got some extra wrinkles in his forehead through what has happened, but he is holding the global public health law, the international health regulations. And in Article 2 here is written, the purpose of this is to prevent, protect against, control and avoid a public health and provide public health response to the international spread of the disease, and not unnecessarily disturbing international traffic and trade. And also in this regulation, there is a paragraph 44 saying that all countries are actually obliged to support each other, both financially, technically, and in keeping an overview and controlling the spread of any disease and infections with a threat of being a pandemic. So I think there's a huge responsibility on the global and international community also to take part in this, and not only looking at what happens within your own borders. And in Norway, we have partly been doing that by also giving what we call a substantial contribution to adding knowledge. And this is a number of updated systematic reviews, rapid systematic reviews that we have done. And they've all been presented in English. You can find them at our website, looking at the emerging knowledge as it's ongoing about aerosol preventing, generating procedures, about the spread of the virus connected to use of face masks, about the different age groups and the immunity, and so on and so forth. And then we saw also the global health leaders of Europe taking a responsibility, and this is Italy, it's Germany, it's Norway, France, and the EU, saying that we want to work together to really save our own part of the world and also the whole world by by collecting money and finding ways of doing this together. As the DG Robert was saying in his opening speech, Robert and Kuna, we are in this together, and an understanding that the only way to get out of it is also working together. And in this chronicle that was distributed all over Europe, they said, we will not be safe until everyone is safe in all world cities, regions, and countries. In our interconnected world, the global health system is as strong as the weakest link, and we must protect each other in order to protect ourselves. And what happened? And this is in Norwegian, and it's written here, almost none are vaccinated in Africa, and that also constitutes a threat to us. Of course it is. And I think it's also a huge kind of burden to say that the world again has shown its way of unjust profoundly when it comes to distribution of vaccines. When it comes to vaccine inequity, we see now in August 2021, only 4% of the population of Africa is vaccinated, or even less in many countries. Mostly is in South Africa and Morocco. In the same time of the year, this year, in August 2021, 85% of the adult population in Norway is now vaccinated. And COVID-19 vaccine inequity will have a lasting and profound impact on socioeconomic recovery in low and lower middle income countries without urgent action to boost supply and assure equitable access to every country, including through dose sharing, according to the new data released by the UN, by WHO, and the University of Oxford. So I think there is something here that we have to deal with also legally wise, and finding a new way of making just to the world in this ongoing pandemic. So these equity perspectives global, they are that preventive measures, of course, they disrupt the economy for poor people. You cannot work from home without electricity and a computer. How to keep hands clean when there is no soap or no running water? Without travel and trade, no food for the day. Indigenous people have been extra vulnerable. There are no tests available and no labs to analyze in many countries. There's lack of hospitals and ventilators. And it's shown that primary health care and universal health coverage is fundamental also to care for and be prepared for COVID-19. And there is a special, I think, focus that has to be on migrant health and also the perspectives of refugees. And finally, 2 slides on what had happened from the evaluation done in Norway. We called it the Corona Commission report of Norway, where they said the country was prepared, but it was unprepared for this, but still at the same time able to improvise while this happened. There has been a lot of lack of protective equipment also in Norway, but the role of this all of government intervention from March 2020 with all sectors involved was a success. And the same you can say about the lockdown measures that were taken early. There is a big trust in the government and health authorities in our country, which has been important. And the societal measures to be discussed has to be discussed against human rights, which has also been alluded to in Norway, like the previous speaker was talking about. And we've seen it as a success in Norway that the municipal responsibility for infection prevention and control has been important and profound and has played a very important role in this. And there has been a high cost and an unequal burden of the pandemic, both within the country and definitely globally. Finally, just a slide to say that the principles of preparedness, I think they apply very much, that the same should have responsibility in a crisis that in normal situation. You should deal with the case as close to the source as possible in the proximity principle. You should deal with it the same way as you normally do, and you are obliged to coordinate both nationally and globally to find ways out of this. And this is an all of healthcare, all of society, all of the world issue. And it has been a disruptive event for the world. And this world, PHEIC, means fake, public health emergency of international concern, which is a term from this international health regulations. It's been a disruptive event, showing also that there has been an opportunity with this disruptive event to develop new solutions, like the one we are working here on technical ways of working across the globe. It has changed, I think, societies forever, and we have to find ways of really working together and live together in a globalized world without destroying the globe. So I think that's also the challenge when it comes to the climate change for the future. Thank you.
Thank you so much to Professor Frode Forland. Fascinating insights into how Norway's been addressing this challenge. I think such useful lessons around the importance of us all being in it together. There is, yeah, I said it before, but our international boundaries are not protecting. They are just lines on a map. And I think, you know, the inequalities are now spotlighted, and our interconnectedness is the theme. And yeah, I loved your closing comment, Prof, around, you know, how do we address this issue without destroying ourselves and the globe. Yeah. So I'm going to introduce you to the facilitator's dilemma. This is for everybody. And maybe I'll couch it in economics as well. I know that there's a demand for further engagement with the speakers. Perhaps the speakers can also give some more of their time, but the context is mediating here, and the context is the full program. So let me invite you to use the chat, not the chat, sorry, the Q&A, if you would like to ask questions to our speakers. I'm going to ask our speakers to track the Q&A that is relevant to their inputs. And if it's overwhelming, have a look at the number in the top left of the question, because it indicates the popularity, I suppose, of the question, because people can vote with that question. So what I'm going to do is create some space for each of our speakers in the segment to respond to some of the questions coming out of the chat as a final round of inputs that I will give to you. and I'd asked you to be to see how you can synthesize the questions in your succinct responses. So thank you so much, Professor Forland from Norway, and it's great to hear that you were in South Africa and are familiar with our continent in your career. I'm going to now invite our third speaker as part of this segment, Professor Wanyenze from Uganda, and she's going to be talking about responses from Uganda, DRC, Senegal, and Nigeria. So from the center of our continent, the warm center, the warm heart, a big welcome to Professor Wanyenze. Over to you, ma'am. I think you on mute. I don't know if it's on your side or our side, but the technical team, if you can just check that we have got audio, or there we go, Prof. Thank you. You are now audible, I think. Over to you.
Thank you, Jeremy, and good morning, everyone. I'm trying to share, but I have a problem with the screen share. I hope it will come forward soon, but thank you for the opportunity to share our experiences in Uganda and the research that we've been doing in DRC and Senegal, as well as Nigeria. Sorry, I have a challenge. I hope you can help to project the slides that I shared earlier. But otherwise, I will highlight very briefly about the COVID-related interventions within the 4 countries. And these are largely similar to what you've been hearing about Norway and also the other countries in the world. And I will focus my presentation mainly on the impact of COVID and the COVID-related interventions on other non-COVID essential health services. This is a critical area which has not received as much attention as all the other COVID-related interventions. Just try again to see. Okay, there we go. Glad it's come up. So I will be focusing mainly on the impact on other essential health services that are not necessarily COVID for most of my presentation. And just to note that our work is anchored within the network for the exemplars in global health, which typically uses a retrospective analysis of countries that have had excellent outcomes to provide an opportunity for adaptation and informing public health decisions across the world. But as you will note, we have made an adjustment within the kind of research that we are doing currently. So it's not necessarily the typical retrospective analysis, but rather a real-time documentation of what's going on in terms of interventions, what's working, in order to inform decisions in the current ongoing pandemic, while we also look at lessons for future preparedness and response to disease outbreaks. So in the exemplars in COVID-19 response, we have 4 thematic areas spanning across essential health service maintenance, testing and surveillance, vaccine readiness and implementation, as well as use of digital tools in the response to COVID. But the focus of my presentation, as I mentioned earlier, will be the impact on health systems and impact on health services beyond COVID across the 4 countries where we are working. So this is a summary highlighting largely issues around the impact on of COVID, which has both direct morbidity and mortality due to COVID, as well as impact on other essential health services. And our research has yielded a number of recommendations, some of which I'll return to at the end of this presentation. The selection of the countries was, again, not done typically in the exemplars approach of starting with the best performance, but rather based on leveraging our networks and exploring the variability of the response strategies as well as outcomes across the 4 countries, but also based on the previous pandemic responses in these countries. And in fact, some of the countries in this network, including DRC and Uganda, have experienced a number of other disease outbreaks concurrent with the COVID pandemic, including the protracted Ebola epidemic in DRC. But we also hoped to leverage the close working relationships that we have with the ministries of health to access the data and also to quickly use the findings to inform decisions across the network. So this slide summarizes the cross-cutting issues across the 4 countries. And all the 4 countries reported their first cases around March of 2020 and responded with various restrictions. These were quite varied, ranging from geographical restrictions in Democratic Republic of Congo to more widespread restrictions in Nigeria and Senegal, including a ban on public transport, curfews, and several other restrictions, and then a total lockdown in Uganda in April 2020. And we are just emerging from another quite severe lockdown, which was instituted in June and July of this year because of the second wave. Then we also have other interventions in common, including the mask mandates, although with various levels of compliance to the masks, interventions to support the most vulnerable populations. And although not included on this slide, there are also a number of interventions, public health interventions, including testing and quarantine, as well as isolation of those who are infected. And although these eventually literally collapsed in terms of the isolation and quarantine at institutional level, and in all the countries, we reverted to home quarantine as well as home isolation. And more recently, we have now integrated the vaccines, although the coverage is still extremely low, on average about 2% or much less across the countries. In terms of what the outcomes were, starting on the left, we can see the behavior, the reduction in mobility across the countries. And the biggest reduction is seen at the onset of the pandemic in the 4 countries around March and April, where travel across countries within the countries was severely limited, and especially in Uganda, as you can see with the bright green. And we can see that this varies across the various phases of the pandemic, with more restrictions coming in during the second wave across the 3 countries. And then the second wave for Uganda, which has just come in June and July of this year. And you can see again the change in mobility, which has come down dramatically and is just beginning to come up as we lift the restrictions. The reduction in mobility that you see in January is not related to the pandemic, but rather to the election that we had during that time and reduced mobility, but which also was coming in after excessive movements during the campaign season, which has perhaps contributed to the emergence of the second wave as we see it. And then you can see the mask on the right. So in terms of the outcomes, we can see that in several of these countries, we had fairly good control for March of 2020, especially in Uganda, DRC, and Nigeria. But we see waves coming in, the second wave for the other 3 countries coming in earlier towards the end of 2020. And then we have the second wave, which is quite high for Uganda, coming in just a few months ago in 2021. And this, like I mentioned, is largely related to the low coverage of vaccination, but also a lot of mobility that came in around the elections and other mass gatherings. And then the emergence of the Delta variant in Uganda. Right now, the genotyping that we are doing is about 100% Delta. And we see that this is also beginning to emerge in the other countries. And there's also, again, an upward trend across these countries. And we can see this both for new cases as well as the deaths across these countries. Although I say this with caution because we also have a bit of challenges with the completeness of the data across both new cases as well as the deaths. Then moving on to the essential health services, we did an analysis of essential health services using a framework that we constructed across the health systems building blocks, leveraging the WHO health systems framework and also leveraging frameworks for resilient health systems from Blanchett as well as Crook and others. And our definition of resilience ultimately is controlling the pandemic while also maintaining other essential health services that are not COVID, because this is often forgotten. And I also need to add that although it's not a focus of this presentation, resilience should ideally extend to other critical non-health services, including education as well as livelihoods, which are also very critical determinants of health and have perhaps not received as much attention during the response. I need to note, though, that while our research identified a lot of interventions across a number of the health systems building blocks, I'll only share a few of these that can be easily adapted and utilized readily. So I'll start with the impact on essential health services using DPT3 immunization for children across the countries as a tracer for vaccination, impact on vaccination, as well as other services. And you can see, starting with DRC on the left, where there were minimal disruption, even at the beginning of the pandemic. And we think this is because of the approach of restricted geographical lockdowns as opposed to very generalized lockdowns that we saw in the other countries. We see in Nigeria a severe disruption coming in around March and April, and a recovery being achieved after about 6 months later. And then we see Senegal again with very severe disruptions of DPT3 and a moderate recovery that started around May. And then we see in Uganda again severe disruptions coming in March and April at the time of the lockdown. And then we see a full recovery and bouncing back to above the previous trends within a period of about 2 months. So we see variabilities across these countries and a lot of explanations around this in terms of not only the COVID-related interventions, but how countries quickly started the other interventions to ensure maintenance of essential health services and limit the disruptions. And we have done this analysis across other indicators, including facility-based deliveries for women, mortality among women, as well as other disease conditions. This is just an example of what we did in Uganda beyond the national level to the subnational level, because we realized that the disruptions can be quite varied across regions, and there is need to be able to do subnational analysis to identify challenges within regions and be able to respond to them in real time. So as you can see, for new visits within the health facilities, we have a major reduction in 3 regions in Uganda, while in 1 region there is an increase. And then we see the diabetic visits going down in 2 regions and no effect in others. So this is just an example of how we can have a lot of variability across regions at the subnational level, and the need for us to do not only national level but subnational analysis of maintenance of essential health services. In terms of the explanatory issues around this qualitatively, we documented gaps in lack of policies and guidelines in maintenance of essential health services across countries, and in fact, a lack of such guidance across the global level and guidance in terms of epidemic preparedness and response. Some of the countries, like for example in Uganda, the guidelines for maintenance of essential health services were developed around April and circulated and training started, and perhaps that explains why the bounce back and recovery happened much faster for some of the disrupted indicators, while the other countries were slower in terms of developing guidance and supporting the maintenance of services across countries. So there is quite a gap in there, and which countries have now started addressing. Then there were issues around a workforce disruptions, mobility for healthcare workers, as well as limited investments in the surge capacity to respond to the pandemic and repurposing of health workers from other disease conditions to COVID. So this meant that we diverted attention from the other public health responses to COVID, and this created a number of challenges, as well as issues with health worker infections and fatalities, and a fear that also affected the response to and sustenance of other services. Here I will highlight the disruption of existing service delivery models like service outreaches for immunization that were suspended across a number of countries because of the mass gatherings that are associated with this, and several other changes in service delivery. And then infrastructure challenges, repurposing of space, as well as other tools to the COVID response away from other services. There was also a disruption not only of the global but local supply chains with stockouts of essential services and rather supplies for sustaining essential health services. But the other issue I need to emphasize on this slide is the poor monitoring of essential health services, because if you don't monitor well, you will not know what's happening to these services. And so we need to do so much to ensure that the data is up to date, it's of good quality, and that we are able to analyze it and in real time know which services are being affected, why, and be able to intervene quickly. So in terms of recommendations, I would just highlight a few, and a need to have guidelines and disseminate guidelines on maintenance of essential health services, non-COVID in this case, and this should also be factored into the long-term epidemic preparedness and response, so that epidemic preparedness and response also focuses on other essential health services and perhaps even beyond health services to other services such as education and how they should be sustained. And then there were issues around healthcare workers and their support, incentives, adoption and use of innovative services, and these need to be thought through upfront and disseminated quickly when epidemics or pandemics such as these occur. And certainly investments in monitoring and real-time monitoring, as well as response to disruptions in essential health services. So in terms of what we have done with these findings so far, we have been engaging as we were going on across countries, working closely with the ministries of health, and shared the findings in each of the countries, but also with other stakeholders, including World Bank, GFF team, as well as during the World Health Summit and the WAHO presentations on surveillance and testing. And recently in Beijing, and we have just finalized revision of the maintenance of essential health services guidelines, including expanding the indicators that we are tracking, as well as expanding this to the subnational levels, right up to the community level. So we have a new guideline now that's recently been completed a few weeks ago, and we hope that we can do better now in terms of maintenance of essential health services. I'm glad that this has also included school health, so hopefully it can help us as we rethink the safe reopening of the schools. In terms of our next steps, we have a lot more work going on, including going beyond health to the unintended consequences outside health, and we are studying education and other impacts beyond health, which we hope we can share, and happy to get your perspectives in terms of what more we can do, as well as where else we might be able to share the work that we have been doing. And if you have any questions, please do reach out to us, and we'll be happy to engage even after this session. Thank you very much.
Thank you very much, Prof. Wanyenze. A fascinating overview of approaches, trends, lessons learned, recommendations, and next steps across 4 countries in the center and the west of our continent. And yeah, comprehensive and fascinating. So now what do we do? You know, this is meant to be, it's a winter school of engagement. We have got questions, we've got time constraints. I'm getting into trouble about the time. So what I'm going to suggest is I'm going to allow each of our panelists, starting with Prof. Pieterse, then to Prof. Forland, and lastly, Prof. Wanyenze, just to respond in a minute, if that's possible, just at a high level to some of the questions. I think the Q&A is going to stay live, so I'm also encouraging, if possible, if our speakers can respond to those questions as well, if possible, in the Q&A part of this app. But let's start with you, Prof. Pieterse, your closing comments.
Thanks, Jeremy. I had a lot of questions, and I've kind of grouped them into 3. I think the most important thing to understand in relation to the questions on South Africa and its systems and perceived weaknesses in the system is that we were not different from the rest of the world at all. Our executive did what executives did everywhere. Where parliaments were strong, it was necessary for them to pass legislation, and then they stepped back into an oversight role. I don't think that South Africa's institutions have been weak at all. Our courts are some of the strongest review powers in the world, and they've shown that they're not afraid to exercise them. I think what we have seen, but we saw it here and elsewhere, is that oversight institutions have been incredibly cautious and deferent because of the seriousness of it all. If you throw something out, you declare something unconstitutional, you are throwing a whole system into disarray, you're sending people back to the drawing board, and meantime, people are literally dying. And so institutions were afraid of exercising their powers of oversight as robustly as they could. And that's something we saw everywhere. I was also asked a lot of questions about what the weaknesses in our system are. I think it has been about integrating our different instruments across silos and across all of society. Our instruments need to be simplified and streamlined across. Specifically, we need to look at intergovernmental relations, and we need to look at the structures that we have that allow for a broader all of society approach. Bring in business, bring in universities, bring in communities, bring in those kinds of things. Those structures exist, but they proved too clunky to operationalize, and so a lot of ad hoc structures were put in place. That actually did work, and so we need to look at what those were. And then everybody voted for the question of, isn't the alcohol ban justified? Absolutely it is. I think alcohol, as with cigarettes, initially it was an attempt by the executive to throw a lot of regulations at the wall and see which stick. And I don't know what that says about South African society, but the alcohol one absolutely stuck. And it was immediately apparent that it was making a difference in its purpose, which was to empty emergency beds. And because no rights are violated when you ban cigarettes or alcohol, your review standard is rationality. The state only has to show that the regulation is sensible, it's in good faith, and it's linked to a legitimate government purpose. And all of those boxes were absolutely ticked with the alcohol. So much as it might pain one to say, it was a very rational regulation. Unusual, but rational. Thank you.
Thank you so much. Thank you so much, Prof. Pieterse. Prof. Forland.
Yeah, thank you. I think I'll pick up one question related to the international health regulations. There were a couple of them, and this is a legally binding regulation adopted by all WHO countries, but there is no real sanctions to it, except naming and shaming if countries don't comply with it. It was supposed to be implemented by 2012, and it wasn't in many countries. But this, of course, requires a lot of capacities in each and every country related to labs, surveillance systems, preparedness systems, risk communication systems, reporting as well. And it means if you have all those requirements of the international health regulations in place, you have a good health system. And of course, it requires a lot of resources in countries. And now WHO has taken on to do what they call joint external evaluations, not only having reporting from each and every country, but having an external team of like 10 reviewers coming now and then to review this country's capacities, which has been very helpful. And then afterwards, national action plans for health security have been developed. And they are also setting up what they now call a global network for health security in WHO to try and really support countries in implementing these measures. So I think there is one thing here with the health system, but it's also requiring a One Health approach and all of society preparedness in these regulations, which is very useful. And a way of working globally is working through these instruments. And just finally to add, in Norway also, we had actually a ban on selling of alcohol in the first phase of the pandemic, and it was extremely controversial. But it has been actually staying as a regulation connected to the opening hours for bars and restaurants. Thank you.
Thank you very much, Prof. Forland. Prof. Wanyenza, you didn't have much time from presenting to seeing the questions, but I see there are two main ones for you. Let's hear your closing comments.
Okay, thank you. So my closing comments is to emphasize the need to broaden the preparedness and response measures and structures to cater for not just epidemics, but to also cater for other health conditions and non-health essential services. This is really critical in terms of mitigating the negative impacts on other health services and outcomes, as well as other essential services such as education and livelihood. Currently, most of these frameworks do not include these aspects beyond epidemics. That's really important. I also need to emphasize, and related to one of the comments that I see about the imperfect statistical results, that we still have challenges with the data that we have in terms of the quality, the completeness of this data and how reliable it might be, as well as the capacities to continuously and quickly analyze and use this data. This is an area for investments as we think about future epidemic preparedness, not only for outbreaks, but also for other services, because without this data, we will not be able to make reliable decisions around interventions and what's working or not working. Then there's the comment on the capacity of the systems to absorb shocks. I think we have seen a lot of examples where the systems were limited. For example, infrastructure being repurposed from other health services to accommodate COVID isolation and treatment. We have seen healthcare workers being repurposed from other disease conditions to COVID. That shows limitations in terms of our surge capacity and the capability to be able to absorb and quickly adapt and respond to an epidemic without grossly affecting other services. So I think that these are indicators, and if we had time, I would have shared a bit more of this, of the gaps that we have within our systems and the need for us to be able to focus more on ensuring that we have resilient systems that can quickly adapt and respond to emergencies. And that goes for issues of governance as well as leadership, because what really drives all this is the governance and leadership ultimately. Thank you.
A perfect way to end, the governance and leadership. Thank you so much, Prof. Wanyenza, and please join me in thanking our three speakers for this fascinating segment of our winter school on regional responses to the pandemic, from Norway to Central and West Africa to South Africa. Nicoline, you are doing what is called graphic harvesting. Can you give us a sneak preview? It's not an opportunity to give a speech, I'm afraid, because I'm about to put us on break, but tell us what you've been doing, or show us what you've been doing.
Let me just share.
If this is the right time.
It's the right time for me, if you want me to share. Let me just share my screen. Hold on a second.
For those of you that don't know what graphic harvesting is, it's a fantastic technique which uses pictures and graphic representations as a summary of the inputs that have been given.
Can you share my screen? Can you see my screen?
It's coming up now. There we go. Thank you, Nicoline. So there you have it. Nicoline, tell us very briefly what you've done.
Okay, so I was just listening out for similarities between the approaches and basically just trying to keep up with what they were talking about. And what I found fascinating from a South African perspective is that, you know, it wasn't so much different in the other countries, because you always think it's worse where you are. So I found that fascinating. And also that this can't be done in isolation, because it's a global issue. So we have to work together, and we only as strong as our weakest link. And that highlights injustices in society that were apparent before the pandemic already.
Brilliant.
So
Nicoline, we're going to be calling on you throughout the next few days, and to our team who's running the sharing of documents and things. Let's get this up on into the gallery. I'm not sure if we can do that, but this is a fantastic summary of the key nuggets from our recent session. So thanks so much, Nicoline.
Perfect. It's a pleasure.
Great. So we are going to take a slightly shorter break. It's 11:13. We will come back at 11:20, not a moment later. And I apologize for the slight delays, but I think you'll agree what a fantastic first three sessions we've had. When we come back, we're going to look at the role of government in disaster risk reduction and disaster response. Please get yourself a cup of tea, have a stretch, and be back here at 11:20 sharp. Thank you very much.